Dr. Lee Gross is board certified in family medicine, and he's the co-founder and senior vice president at Epiphany Health. And this afternoon, he is going to discuss how a direct care revolution can save the future of healthcare in America. Please help me welcome Dr. Lee Gross.
This thing, can everyone hear me all right in the back? Well, I have to tell you, it's pretty neat to come out to a venue like this because, I'm used to going to these programs all around the country and hearing people just complain and just list the problems that there are in healthcare today. But it's so enlightening to come to a program like this where we're actually hearing solutions, because if you watch the news, all you hear are there are no solutions. There are no alternatives to what we've experienced. And so to have so many like-minded people in one room is really very exciting to me. We don't always have so many agreeable minds in the room when we give these presentations. And I was sitting the last couple days with the group of the medical students through the Benjamin Rush Institute, and it reminded me, I gave a talk for the American Medical Student Association's Empowering Future Physicians Conference at the Rowan School of Medicine in Philadelphia last year. And I was the first speech. And if you don't know about the American Medical Student Association, they left the AMA because they thought the AMA was too conservative for them. So politically, they lie a little bit to the left of Stalin. And so to come in with a free market healthcare speech is not something you would expect at an AMSA conference, but I was the lead speaker there. And the president of the university gets up before me and proceeds to give this wonderful speech introducing the conference and how exciting it is for these students to be practicing in the new era of medicine beyond healthcare reform, and the new exciting area where they're going to practice team approaches and working with the care plans. And it was the worst possible introduction you could possibly have to my talk. So they call me up to the stage, and I don't know if any of you have seen the movie My Cousin Vinny, one of my favorites, but I wanted to sort of channel that and just sort of, with my opening remarks, say everything that guy just said is bullshit. Thank you. I mean, that honestly could have been my entire presentation. But so in the course of doing what I do, I've done a lot of traveling around the area. We've made lots of trips to Washington, D.C. And in fact, I think, Keith, that's where you and I first met each other, is in the lobby of the Heritage Foundation when I was there one time. But we call on members of Congress, and we try to offer meaningful solutions to them. And for the first couple of years we went to Washington, we could only get meetings with the Republicans. The Democrats wouldn't even schedule an appointment. We couldn't get in the door. And so about our third trip, we started to get a little bit more recognition on the Hill with our organization, Docs for Patient Care. And we had a little gap in the schedule, and one of the members on my team was from North Carolina. She said, you know what, my representative, his office is right down the hall. Let's just see if he'll stop and see us. Well, I wasn't planning on this meeting, but so I took down some notes here, and I still have copies of the notes. And I went in, he agreed to see us, a fellow by the name of Larry Kissel from North Carolina. Democrat, did not vote for the Affordable Care Act, but he would not vote to repeal it either. And I sat down, and I handed him my brochure that you see sitting on your table there. And I listed some things. I said, if you were to design an ideal healthcare reform, what would you consider to be some of the key pieces that you'd really want to include in that? And I said, you'd want complete price transparency. You should know what everything costs. There should be no surprises. You'd want to have all routine medical care and preventive services. They should be affordable for everybody. There should be no barriers to access for routine services. You shouldn't charge extra because somebody has a pre-existing condition to get routine care. And in fact, ideally, you wouldn't even have any fee for service for routine care. It should just be fairly simple to get the services you need. It should encourage wellness. It should allow portability, be so affordable that you can take it with you wherever you go. It should incentivize people to pursue a career in primary care medicine and expand the primary care base. It should encourage doctors to actually see patients that have Medicaid and make Medicaid a viable program again. It should reward physicians that provide better services. If you're a better doctor, you should get paid a little bit more. It should improve viability of rural practices, simplify the incredibly complex billing practices, and reduce unnecessary hospital admissions. And I said, you guys collectively passed the 2,700-page law. You've so far written about 100,000 pages of regulations, and you've done almost none of those things, but in the trifold brochure I have on your lap, we've accomplished all of those things. And he's looking at this thing, and he's flipping it back and forth, and he starts seeing the pricing in here and gives a big smile, and he said, I've seen public policy pieces and white papers from every major think tank, left side, right side, any political spectrum, he said, and I've never seen anything so brilliant in its simplicity, but it's not going to work. And I said, why is that? And he said, because nobody gets rich off of this. He's not in office anymore. So Epiphany Health, that's a crazy name for a healthcare company. So what was our epiphany? Next slide, please. I'm going to try not to repeat a lot of stuff that's been said over the last couple days. But at the end of the week, my friends and I would all get together and have the same conversations we heard about the last 2 days. Why is this so complicated? Why do we have to keep doing this? Why do we have to do step edits and prior authorizations? Healthcare shouldn't be this complex. And one day my friend called me up and said, I got a strange call from one of my patients who owns a heating and air conditioning company with 10 employees. And he said, Doc, I pay Blue Cross Blue Shield $1,000 a month per employee for their health insurance. Almost every single one of them sees you as their doctor. Why don't I just pay you directly, get a catastrophic health insurance policy, and even if I pay their deductible, if they hit it, I'm still going to come out ahead. Ding! He said, is this something we could do? And so we started to research it and said, what does primary care really need? We need some affordable access to labs. We need affordable imaging. We need just basic supplies. We maybe need some physical therapy, affordable medications. And if we have those things around us, we can really do our job pretty well. So next slide, please. So everybody in this room, I think, sort of based upon this talk yesterday, knows what direct primary care is. It's a membership-based program, a per member per month type thing. Unlike Atlas, our program is probably different than many you see in the country because we have a hybrid program where I have a full practice of traditionally insured patients. I have well over 3,000 patients that have Blue Cross, Cigna, United, Medicare, and so I am a Medicare provider. But I added the direct primary care component as a hybrid onto my practice back in 2009. And once we did that, we stopped accepting any patients with traditional insurance beyond that. They could have a high deductible plan, but no new Medicare patients, no new traditionally insured patients. Any new patient that wants to come into our practice from that point forward needed to join our membership-based program. Next. And one thing that we also did that was different, you can keep it there, that we did was different is we built a full network around us to provide these major discounts. So we're contracted. We have contracted rates with our local cardiologists. We have 4 pharmacies under contract. Unlike Atlas MD, that they do dispensing of all prescriptions, or their generic prescriptions in-house, I really didn't feel comfortable being a pharmacist. We didn't feel comfortable running a pharmacy out of our practice. So we just went to the mom and pop pharmacy up the way and said, we need a price on prescriptions. And we just signed an agreement that said you'd honor it if our patients came here. We did the same thing with the surgery center. We want a price on a colonoscopy, bundled price. We want a price from our cardiologist. And we didn't twist any arms. We just said, give me your best price for your top 10 procedures that you do. It's not charity. Our patients are going to agree to pay you at the time of service. And if they do, what will they pay you? And they listed their prices, and you'll see some of those prices a little bit later. But we have rheumatology, nephrology, cardiology, GI, general surgery, 2 physical therapy groups, and so on. Next. So we've been talking about this. That's all we've been talking about is the free market. And everybody knows in the free market, the healthcare prices, or the prices of new technology come down over time. So a 32-inch LCD TV screen that comes onto the market at $725, before you know it, you have more competition in that category. More people are making TVs. They find ways to make them better, make them cheaper, and before you know it, it's a $200 Black Friday special. Next slide. But this is what's happening in healthcare. And so the people that, sort of argue with the free market approach. They say, we tried the free market. This is what it did. This is not a free market. Competition that we see in fixed price healthcare is not competition in a free market setting. So if you have, I trained in Cleveland, so we had Cleveland Clinic and Case Western Reserve University hospitals sitting right next to each other, and it's a building war. They've taken over the entire city, but none of them have brought down the cost of healthcare. But there's plenty of competition in that market. Other examples is you can look at LASIK eye surgery versus cataracts. The price of cataract surgery keeps going up, 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 up. Now LASIK eye surgery is also going up, but not nearly at the rate it was. It's done by the same surgeon in the same exact facility, but one is paid by third parties, the other one's paid by the patient. And so you can probably get a buy one, get one on Groupon now, I think, for LASIK surgery. Next slide. So we touched on this a little bit. Doug mentioned this. You don't use your homeowner's insurance when the light bulb burns out. You don't use it to mow the lawn. You don't use it to repaint your house. Why would you use it for routine care? Why would you use it for a stubbed toe? Why would you use it to manage your diabetes, your high blood pressure? These are expectable things that should be affordable for absolutely everybody to access. And the one comment there about the third parties at the bottom driving up the cost of care, the interesting thing about having a hybrid program is seeing insured and cash-paying patients in the same practice. The mindset of the patient is completely different. When the patient's paying $1,000 a month to Blue Cross Blue Shield for their insurance, they want the MRI. Whether or not they need it now or not, they want the MRI. When we go through the scenario with the other patients and say, look, I know you twisted your knee, you're not a professional athlete, we don't need to get you back on the football field tomorrow. Let's go ahead and give you a cortisone injection, give it a couple weeks, see how you feel. If you're not feeling better in a couple weeks, we'll send you to physical therapy. That's going to be $35 a session for physical therapy. If that doesn't work, then we're going to go ahead and send you for an MRI and set you up to see our surgeon. But if they want that MRI, we'll get it for them. It's going to be $200. But the explanation is $200 for the MRI. I'll tell you what, if the MRI shows a small tear, I'm going to do a cortisone injection. And if that cortisone injection doesn't work, in a couple weeks I'm going to send you to physical therapy. And if that doesn't work, I'm going to send you to the surgeon. Again, it's a different approach. It's really eye-opening the way you can approach these people. But once you start factoring the costs in, it really is a really neat interaction with the patient, a real pure relationship. Next slide. So we've been talking again about this. If we're trying to put everything into a box and sell it for one price, we're going to call that box coverage or insurance. And you're trying to bundle an affordable package of primary care, and you're putting that same thing in the same box with end-of-life care, pacemakers, chemotherapy, you name it, rehabilitation, you're selling it all for one price. It basically artificially drives up the cost of access to primary care. But if you separate those two out, next slide please, the cost of access to primary care comes crashing down to something that is really cheaper than probably most people pay for their cell phones or their cable television. Next slide. And the reality of it is that it's pretty unusual that we on a routine basis have to send people in for specialty care. We don't claim to be all things for all people. We can't solve all problems, but for the average person, we really can do what they need within our office. Next slide. So we created the Epiphany Health solution for this. I'm just going to start showing you some pricing on that. We already know how it works. Next slide. So you probably can't see this real well in the back, but what we do is for the prices I'm going to show you later, we include 25 office visits per year at no charge, no copays, no deductibles. If somebody comes in 25, it's never happened, but that's every other week for a year. It's not going to happen. We include the Pap tests, we include the mammograms, we include the routine vaccinations, the pneumovax and the tetanus boosters and the flu shots, and anything we can do in our office is included at no additional charge. Next slide. The only thing we don't do is we don't write chronic pain prescriptions. We don't prescribe chronic narcotics, chronic controlled substances. We just eliminate that on the front end. In Florida, we've got reputations for being pill mills, and we just don't want to even be seen as exchanging cash for medications. Next. So just to kind of give you an idea of the routine costs for the stuff that we do at no extra charge, Joint injections, we'd normally charge 150. Skin biopsies, I have 160 here. I actually had a squamous cell cancer taken off a little while back, and after using my insurance, which is against my better judgment, my out-of-pocket expense was about $1,000. Okay. The other day, well, a couple weeks ago, I had a patient that came in for a lesion on her back. I did a punch biopsy. The technical part of it, I didn't charge to do the biopsy. I sent the biopsy out to pathology. There was a $30 fee to the patient to review. Came back as a squamous cell carcinoma. Patient came back the next week. I excised it, sent the specimen out to pathology, confirmed that we got clean margins, and that was another $30. So the patient paid $60 for that entire thing, and I didn't charge anything for what I did. And I paid $1,000. So again, I mentioned that we sort of contract with some folks outside, some like-minded physicians around the community. To give you an idea, a nuclear stress test we can get for $520. CT scan of the chest, just a little over $200. That's with contrast. I got a chest X-ray for about $20. So we've seen all sorts of prices on colonoscopies. Our prices about $1,100. That includes anesthesia, that includes facility fee, and it includes the surgeon's fee. This is an actual hospital bill from a hospital that I am on the board of trustees of, so this is kind of fun. This is an actual patient of mine that went to the emergency room for abdominal pain, and they were there for about 8 hours. They had CT scans and x-rays, and you can see everything's itemized here and the cost of it. I'm going to summarize it on the next slide because I know you can't read that, but you can see everything spelled out there. Next slide. So the actual billed charges, which we know is fantasy, was $19,723 for this patient to go to the ER for abdominal pain. If that same exact patient had called our office, we can see patients same day, we see all patients same day. We can send them for stat labs, we can send them for stat imaging, we can do all that stuff, work them up through our office. So our actual charge to the same patient coming to us would have been $278. That's the difference in what the patient pays, with the price transparency. And we have all these prices listed. I have a menu of everything in my exam rooms. I know to the penny if I'm sending a patient for a test, I know what it's going to cost them. Next slide. So we charge $80 a month for an individual. We charge $150 for a couple and $175 a month for a family of basically no matter what size. We really don't put limits on that. We also offer discounts for veterans as well. We bring that price down to $50. Now keep in mind that these prices, when you compare them to Atlas MD where they charge $50, our stuff includes all the ancillary stuff outside, the mammograms, the pap test, the blood work. They have access to those through them. We just bundle it in. Next slide. So for a typical family of 4, under our program, it costs them about $175 a month. Now, if you look for 2013, now this is before the Affordable Care Act went into effect. So 2013, the average price for a family of 4 for a PPO program was a little over $1,800 a month. So the difference between their program and ours was about $17,000. But let's go ahead to the next slide.
That doesn't include their deductible.
That doesn't include their deductible. So let's just say that instead of that, the patient signed up for a $10,000 catastrophic deductible, and they also paid our membership fee in addition to that. Okay, so they're paying for 2 things now instead of just one, but they're paying for 2 programs: their coverage and their care. The cost of that over 10 years will be $51,960. Keep in mind that those patients will not pay anything to come into the office. They're not paying copays. They're not paying a penny to get their routine care. If you look at that versus a standard PPO contract, I forget what the price is here, it didn't show up on here, but the net savings over 10 years is $168,000, the difference between those two, okay? Now let's just say $10,000, that's a high deductible. People don't want to pay $10,000. Let's just say this was the sickest family in the world, and they hit that $10,000 deductible every single year for all 10 years. Remember, we saved them $168,000. Take off $100,000 from that, they still save $68,000. Next slide. So this is that employer of 10. This is how those numbers work out for the employer. So again, same exact thing. If the employer bought a $10,000 catastrophic policy and paid for the membership, compared to what their traditional PPO costs would be for that employee, the net difference for that employer is almost $1.7 million over 10 years. That's the net savings. Again, the employee doesn't pay a penny to get care, so you're providing basically 100% of the routine care costs. And again, this is the best employer you could ever imagine. They're going to say, you know what, I'm going to pay 100% of your deductible if you end up getting sick. And if all 10 employees hit their $10,000 deductibles every year, we still only save the employer $700,000. Next slide, please. So how can we do this for so cheap? Well, we charge that patient at $80 a month, about $960 a year. Our cost on the labs that we include in there is $30. That's wholesale purchase of labs through our lab contacts. Our cost on the mammogram is $25. I contract with the imaging center. I pay the imaging center. They send me a bill every month, and I write them a check for it. So the patient's not paying that. My cost on the flu shot is $6. My cost on the interpretation of the PAP test is $28. I pay the pathologist. And at 25 office visits, we run about a 50% overhead. So next slide, please. Basically, if you factor that in for about 500 patients in the practice, after you take off the overheads, a family doctor is going to be net afterwards is about $220,000 a year. Not bad for a part-time practice. Now, because we have it as a hybrid, we don't have 500 patients in our practice. We have closer to 300 because we still have to see the our full range of routine patients. Next slide. So if we look at this on a national level, leading into the Affordable Care Act, we talked about that we have 58 million people that have no coverage. And that was the problem we were trying to fix with the Affordable Care Act, is getting coverage to 58 million people. Now, many of these newly insured or newly covered would likely be in the Medicaid expansion programs. The assumption was that under this program, we were going to get 32 million covered, but they already conceded that 26 million people will remain uncovered after the Affordable Care Act's implementation if everything went perfectly. And again, assuming the Medicaid expansion. So that was conceded, and the cost on that's $1.8 trillion over 10 years. Next slide. So instead of getting coverage, and of course we talked about earlier that you have the Ferrari, but you don't have the keys. If you have coverage, but nobody is going to accept your coverage, it's worthless. If you expand Medicaid and nobody accepts Medicaid, it's worthless. So instead of giving coverage to everybody, let's enroll everybody in the country in an Epiphany Health-like program or direct primary care program. Now they have coverage for all their basic needs. They actually have care for all their basic needs, and the net 10-year cost on that is now $556 billion. Next slide. For a total savings of $1.3 trillion over 10 years. These are the types of things that if you had mass adoption of these types of programs, that you absolutely can see ways of providing affordable care to everybody. This has been a real interesting ride because when the Affordable Care Act rolled out, what they essentially did was they took a lot of money to provide primary care services to the indigent away from county health departments. They transitioned that money over to federally qualified health centers. And so what that effect had on the local level for us is our local health department primary care program shut down. And they sent out letters to all their patients saying, we've lost our funding. You have two choices. You can go to the federally qualified health center or go to Epiphany Health. And I can tell you the federally qualified health center was not happy that the county sent out a letter sending somebody to a private corporation. Our phone was ringing off the hook, getting people that were on public support, getting all their care paid for by the tax dollars, are now finding it affordable to pay their own way. But another interesting observation over the years is that we decided at one point we were going to donate a dozen memberships in our program to the County Homeless Coalition. And we offered transportation for these folks. And basically, when we give it away for free, we've established that this has a value of $0. And that's exactly the value they placed on that. Because even with all the arrangements that we made, these people were in transitional housing, we weren't dragging them off the streets. We were giving them free services for a year, and we probably had a 95% no-show rate for the patients in this program. I'm going to close a little bit early here just because I know there's probably some questions, and some of this stuff is repetitive. If you could go to the next slide here, and then one more after that. A lot of people wonder how we could do this hybrid practice because the challenge is, if we're trying to massively expand this type of program, you're asking an established physician with 3,000 plus patients to kick all their patients out and hope that they come back in and pay the fee. Having kids and having a mortgage and having a full staff and leases, that's a lot to ask somebody to make that sort of commitment, to take that sort of leap of faith. I certainly know that we didn't have the courage to do that, and I commend Doug and Josh for being able to do that right out of the gate. I don't know many people that have that sort of risk tolerance. But nonetheless, what we've done is added a separate program, so there's actually zero risk. I mean, if not a single patient enrolls, we've lost nothing. Now, granted, we spent a year and a half vetting this out, getting legal opinions, getting accounting opinions, tax opinions, and spent a lot of money vetting it because there was nobody to model off of at the time we were doing this. So, talk about taking the arrows. We took the arrows when we did this and spent a fortune along the way, but we learned a lot of important lessons. And I'm still learning lessons from people that are doing it after us, or alongside us, I should say. But the way we've done this, and this has been talked about before, is how do you have separate pricing for different people within the same practice? Won't you be violating your insurance contracts? So I can't have completely separate fee schedules, one for Blue Cross Blue Shield and one for self-paying patients. It's almost violating my PPO agreements that I have with these people to have different prices. So what we've done is we set Epiphany up as a separate entity, and our patients contract directly with Epiphany Health. And then my practice then contracts with Epiphany Health as well as a service provider for them. And I just agree to see those patients at a contracted rate. So it's just like I signed a contract with another insurance company. Now, Epiphany is not an insurance company. It acts more like a third-party administrator, essentially, coordinating benefits and payments for things. The patients pay Epiphany. Epiphany pays me to take care of the patients. So this is really set up in a way that you could add any practice anywhere in the country to get our Epiphany's pricing, to get the structure of how we do things, sort of designed to grow. But that's really sort of our little trick on how we kind of got around the different contracted rates. So I think with that, I'm just going to open it up to some questions because we probably have a few out there.
Questions for Dr. Gross? Yes, ma'am.
So it's just an example of a member. Let's say it's a family of 4 with a child who has asthma.
Yes.
And also requires care for, with a pediatric pulmonologist. Like, how do you arrange that? Where does the payment for that specialist, who probably is not utilized as frequently by other members, is that coming out of the pocket of that membership? Does that family have to consider that? Like,
Well,
how
yeah.
do those complexities fit in?
Yeah, and again, sort of going back to what I said before is, we can't solve all the issues. I mean, this is that child actually probably would do very well in our program because they probably need to see the doctor a lot. Practically, where I speak, the nearest pediatric pulmonologist is probably an hour and a half away, so that's just not even practical to even see somebody in pediatric pulmonology. But yeah, I mean, so for example, let's use probably rheumatology would be a better example for this. So I had a patient with rheumatoid arthritis that had no health insurance, and she was trying to get care for her rheumatoid. She went to see the rheumatologist. She could afford the rheumatologist's fee, but when he sent her to the lab and sent her for the x-rays of both wrists, both knees, both elbows, both shoulders, the lab quoted her $1,800. She probably had over $1,000 in imaging studies that were ordered. She can't do that. She can't afford that. She can afford the $200 office charge, but she can't afford the $2,000 in stuff. So when we reprice her labs from $1,800, we reprice them at about $80. Okay, we reprice her X-rays probably about $100. So she can afford now she can afford the rheumatologist's fee, but she can also afford her labs and her X-rays that the rheumatologist needs to get her job done. So although we don't solve all the problems, we can make a lot of things work smoother. But the cognitive specialties really are not the rate-limiting steps here. The endocrinologist fee and the nephrologist fees, their office fees are not really. That's not what's driving the high cost here. It's the prescriptions are huge. We can get very creative, and I'm happy to meet these folks over here at this table as far as bringing down prescription costs. So for example, using physical therapy, if I pull out my Blue Cross card and I go down the street for physical therapy, my copay is $50 a month. If I put my card in my pocket and don't use it, it's $35, or a visit, it's $35. So we see that all the time, the savings, that if you just left your insurance card in your pocket, how much money you'd save by not pulling that thing out. Other questions?
Could you comment on selecting patients, and if you had any inclusion-exclusion criteria, if you're drawing from your large panel, who was a better fit for this model? And
Everyone heard the question. So initially when we threw the switch, I don't know any practice that doesn't have a sample of self-pay or uninsured patients in it. That was easy pickings for us. So the day one we flipped the switch, we had 50 patients sign up. Because they're already there. You're in your practice, you're providing them basically an offer they can't refuse. They'd be crazy not to take it. We're finding that probably the patients between 40 and 64 probably utilize this the most. That's really our prime target. These people are old enough to need to see the doctor 3 times a year. They may have a high blood pressure, develop diabetes, heart disease. So these patients definitely find value. The younger folks, probably not as much. If they've got some chronic conditions, definitely. So I have a lot of kids with cerebral palsy and stuff that we see that need to come in. Doug's comment yesterday as far as, are we competing against ourselves to some extent? Yes, we are. Because if we want everyone to sign up for membership, but we're also allowing them the option to use their insurance instead, well, why am I going to pay you $50 a month when I can pay a $10 copay? Yes, in that regard, we are competing against ourselves, and that is why we have 300 and not 500, 700 patients in the program. And again, why haven't we just flipped the switch and gone completely third-party free? Probably a lot of factors. Again, one is boy, that's a scary thing to do. Everybody out, thanks for coming, and hope that you get it to sign back up again. But we're in an underserved community. It would not be we are very big in our local community. I'm not trying to pat myself on the back, but if our practice jettisoned 7,000 people into the general community without a doctor, there would be hell to pay for that politically. So we will do it on a more subtle basis as we go forward. So I just got a letter this week, and this might be the first one I get rid of. United Healthcare just sent me a letter saying we're now going to have to start prior authorizing certain blood tests, certain laboratories. So we'll see how that goes, but that might be the one to make me pull the trigger on now.
Have you thought of a second tier pricing to try to get healthy people into this?
Yeah, I didn't include it in the slide because it's not in the brochure. We actually do have 2 completely separate packages now that we offer, and it's not even on our website because we're completely overhauling our whole website. But so the way we have another package. It's if you have traditional insurance and you want to use it, but you still want to see us more as a concierge, it's $50 a month per person. We don't have the age restrictions that some of the other practice does. The first child's $25 a month, and each additional child's $10 a month. Now, with that, we're not including blood tests, we're not including mammograms, we're not including Pap tests. We'll submit those things to their insurance like they normally would because it covers it. And so some people that felt like they were sort of paying twice for stuff, then they're more apt to come in on that price point. That's sort of the challenge that we have now with sort of these Affordable Care Act policies. The Bronze Affordable Care Act policy, it has a $6,500 deductible and a 40% coinsurance up to $12,000. But their Pap test is free, their mammogram is free, their physical is free. So they don't see the value in including those things into our program because it's already free. But with everything sort of being bundled into that package, you now have a $6,500 deductible that's far more expensive than the $10,000 deductible previously. That's with the new plan designs. But so our challenge, I think, is at this point really trying to find good wraparound insurance policies that don't duplicate services. And that's, again, why I'm happy to sort of meet some of the people here this weekend that might be able to help us do that using sort of captives and creative ways to work with small businesses to provide care to their employees. You know, one of the things that, you know, our business plan, you look at how large corporations bring down the cost of care. So if you look at the school boards or you look at the county, what they do is they bring primary care in-house, and they'll hire a nurse practitioner and they'll staff a clinic in-house and say, if you use our clinic, it's free. We'll give you free medications, whatever you need, it's free if you go to our clinic. Well, if you have 1,000 employees, you can afford that. If you have 15 employees, you can't afford that. So we are able to contract with small businesses and say, we'll be your in-house clinic. If your employee comes to see us, they don't have to pay anything. So we can divide that same concept over 10 small businesses as opposed to one large business. You know, the challenge, of course, I was talking with Adam earlier. He said there's no minimum in a state to self-insure. And although he's accurate, we discussed this afterwards, there is no minimum to self-insure. States do have minimums to provide to provide the catastrophic coverage. There are minimums for stop-loss provisions. So where I happen to live in Florida, it's 25. So you can't get a stop-loss provision for if you have less than 25 employees. Well, try self-insuring without a stop-loss policy. It would be crazy to do it. But if we use what Keith was talking about the captives, you can now sort of pool various small businesses together, sort of share risk, and now they're able to purchase stop-loss coverage as a group. So that's sort of the next step of where we see this going.
Have you started to try to spread this? Have you started trying to spread this to other groups? What kind of success have you had? And if or when that happens, are you linked to those groups or are they separate?
Right now, this has been pretty much a labor of love. I mean, I travel all over the country talking to as many people as I can about this because what I want to do is create demand for it. I want people to know that this is possible to do. I want businesses to know that this is an option for them. And so what we're trying to do is ramp up demand and and get everybody excited to know this is even a possibility so that we can get everybody on the same page with this. So although we are certainly designed to expand, we didn't have a specific expansion plan in mind. The Heritage Foundation recently did a piece and they tried to analyze how many of these types of practices, direct primary care, and they looked back around, I think it was 2010, and I think they referenced about 100 practices, and then they referenced 2013, and they said 4,000. I think those numbers are wrong. I think they blurred the lines between concierge and direct primary care quite a bit. I think they way overestimated. I probably put the number closer to 100, maybe 200 that are doing this nationwide. But as more people are learning about it, it's definitely has capability to grow. But I think some of the key limitations to the growth of it are, number one, most doctors are not going to terminate an existing practice. They're not going to feel comfortable doing that unless they have excellent support, which Atlas MD has really been doing a great job on that front. And the true wraparound policies are just not available anymore. So if we could get legislation enacted that brings back the true high deductible catastrophic plans again, I think that's a very doable thing. I think if you're able to, again, re-expand the HSA contribution deductions, I think that's a very doable thing. So those are things that would certainly help expand this sort of thing on a national level. I can tell you that no matter what group we go talk to, no matter what side of the political spectrum you're on, this is universally praised. I mean, there's not... probably the one criticism I got, one of the times the first talk I gave in Washington, D.C., the first question out of the audience was, well, you charge $80 a month. What if the guy next to you sets up and charges $40 a month? And I was sort of taken back. I didn't expect that. And I said, if the first question out of the box is, what are we going to do when the cost of healthcare comes down? I said, that's great because that conversation has never been had in the United States before. But, it's an interesting concept. I said, but what's probably going to happen is he and I are going to have to start competing on price and quality. I'm going to have to justify why I'm charging $80. I may have to bring my prices down. He may find that he can't keep his doors open at 40 and bring his prices up. But, you know, and I remember Keith one time when we were in Michigan together giving that talk, and you know, when he says, "I don't know if my prices are right until I get the competition." You know, I don't know if my price is right until we start seeing more practices popping up and seeing what's the true market value for the services we provide. We're finding out, which brings me to another interesting point in dealing with the politicians. I'm working with some legislators in the state of Michigan on putting together a pilot program for Medicaid, which allows Medicaid and direct primary care to sort of work together. And I was having a conference call with the chief of staff of the Republican House of Representatives, and he and I we just couldn't get our heads together on this, because he absolutely insisted that the government be responsible for paying the direct primary care directly, and I insisted that that money needs to be deposited into the patient's health savings account, and the patient needs to shop around for the best price. Because I said, you guys have a practice up in your community that's charging $40 a month, and if I'm down here in Florida and you say Michigan will pay $40 a month for primary care services, and that's it, why would I expand to Michigan if I'm getting $80 down here? But if we could go and provide some competition, the patient actually can choose how to spend their money wisely. They're going to shop around for what they perceive as the best deal. So it's interesting, because once they get their tentacles in, nobody wants to get their fingers off of medicine. So that's been an interesting challenge.
And
One
just
more in the back. Thank you.
just a comment as well. First of all, I mean, this is fantastic having you and Keith and the guys from Atlas. I mean, as I said, you were kind of like the founding fathers of this movement, and you gave me a lot of inspiration to do what I'm doing, which was basically to take the huge leap that you're talking about. And you know, at the end of March, I was a traditional doctor doing fee-for-service, taking insurance and Medicare. On April 1st, everyone thought it was a joke. I went third-party free. And just a comment that if you do this, you do have to be very strong-willed and have a support system, because there is no way to predict who will stay with you and who will not. I had people that I knew had millions of dollars in the bank, and they left me right away. And I have people that I know are dirt poor, but they value the service, and they stay with me. So whether the person is affluent or not has nothing to do with whether they stick with you or not. It's really, what value do they see in what you do. So again, just a comment, you have to be financially and mentally prepared for a roller coaster if you do that.
Thanks for the comment. I would also add one more thing. You would think that our biggest naysayers would be the insurance companies sort of feeling threatened by what we do, and we're certainly trying to put some protections in place for doctors around the country to do this legislatively. But our biggest threat was by a large physician group that basically sort of said, we think you guys are operating in an illegal insurance company. With the way you guys are doing things, and wink, wink, nudge, nudge, we'd hate for something to happen to your practice. So that was probably the biggest threat we've actually gotten, was from actually physicians. It was interesting. Yes?
Thank you, Dr. Groh. Thank you for your presentation. In our little community in Southern California, Torrance, the city of Torrance, which is about 15 miles south of downtown LA, we have at least 6 concierge practices that I know of on primary care. And 2 of them are very close friends, and one of them is a hybrid. One of them is pure concierge. He's 70-some years old. He's been doing it for 9 years. 9 years. And he has a lot of utilization, but he enjoys it. And so all the patients that sign up with him are the ones that are high utilizers, from different backgrounds, as Dr. Camper said. It's the rich don't necessarily sign up, and not so rich may sign up more. There is really no schedule, no algorithm that you can predict. But that doesn't mean that you're not providing an extremely valuable service for your community, regardless of what size it is. And it just emphasizes what this whole weekend has been about.
Yeah, just to sort of expand upon that, we were doing a health fair up in Sarasota, and we were just trying to reach out to at a college up in Sarasota, we were trying to reach out to the parents of some of the students that might not have insurance, and one of the booths a few over from us were the navigators from the Affordable Care Act. And so they started roaming around looking at the booths. They got to our booth, and we had no insurance, no problem, asked us how to get affordable health care. And she said, oh, this is really interesting. What's this about? And I said, well, we're here to take care of the people that don't have health insurance or can't afford it. And she said, oh, yeah, we're here signing up people for policies. I said, yeah, but since Florida didn't expand Medicaid, your policies for people between 100 to 138% of Medicaid or of poverty are $650 a month for a $6,500 deductible. These people can't afford that. She said, I know, it's awful. I said, yeah, it's awful. Then she said, but we really need to expand Medicaid. And I said, but nobody takes it. And I said, we have a share of cost Medicaid in Florida, which means every month they have a new deductible they have to meet. It's $500 every month. And if they had $500 a month to spend on health care, they wouldn't need Medicaid. And she said, I know, it's horrible. And I said, yeah, but we fixed that. She said, that's fantastic. She took a whole stack of brochures, so now I have the Affordable Care Act navigators are my best marketing team right now.
Lee, talk for a minute about how you actually collect from the patients, the logistics, the mechanism.
Yeah, so as far as collections go, everything is electronic funds transferred directly from a patient's checking or savings account. We do not take credit cards for this at all. The fees fees for credit cards are fine when you're taking co-pays, but when every month I'm getting $9,000, $10,000 being put on a credit card, that fee is not worth paying. So, and we got no pushback whatsoever on the patients when we said we are not doing credit cards on this, only your checking or savings account. So not a single person refused that. It doesn't really cost us anything to do that. Our monthly billing consists of click. Money's in the account the next morning. Yeah, it's a piece of cake.
So you don't have any charges for running debit cards?
We don't run debit cards. This is a purely
So you don't have any transfer charges to do direct?
not through our bank, through our merchant account, through our bank for just straight electronic funds transfer. There's a batch fee, but it's $8. And we run 4 batches a month, so our collections are $30 probably. Yeah, it's not it's not based upon a percentage. It's based upon a transaction. And so we bundle everything into 4 transactions. We don't, if a patient signs up, we don't put that funds transfer through immediately. We'll put them into, we used to do 2 batches. Now we do 3 batches a month. So we only pay that fee 3 times.
You said you had 50 patients come over when you initially launched the program, and now you're at 300. I know I've talked to a lot of primary care doctors trying to do what you're doing in like patient acquisition, education, letting patients understand how the practice works. What have you found to be effective in terms of bringing those other patients in and teaching them the value of your practice?
That's a great question. We're still working on that, to be honest with you. You can never beat word of mouth and patient testimonials. The people that come into the practice. We give talks around the community at various events, reaching out to small businesses, Chamber of Commerce. We found to be helpful. Print ads, as far as I'm concerned, are worthless. It's much better to have somebody write an article about you, a story about you, because that gets the phone ringing off the hook when you have that sort of thing. But yeah, it's not overnight. It's certainly, if I were to, it's much harder to get somebody to switch physicians than it is to get somebody to change the way they're paying their established physicians. So, if I did pull the trigger, I'm certain we would be up, 600 plus patients of our established patients. But for the reasons I mentioned earlier, we're not doing that.
Well, thank you, Dr. Gross.
Thank you.